Now, if you want wise words about EASD, there is only one person to turn to, and he's with me now in our studio, and that's Leszek. And I'm not going to say his surname because he's Polish, and they are almost impossible to say for the British. So, your surname is?
My surname is Czupryniak, but you did very well with my first name. It's Leszek. So my full name is Leszek Czupryniak, yes, and I'm from Poland. I'm currently the head of Diabetes and Internal Medicine Department at Warsaw Medical University, but I've been involved in the EASD activities for, I would say, like 15 years now, mostly being active in running courses as a postgraduate education activity of the EASD. I was also the member of the executive committee. So, yeah, it's the annual meeting of the EASD is the highlight of the year for me.
So you've been around the block. You're a very seasoned observer of the EASD. For you, what are the big themes that are emerging this year?
Well, this meeting is special. We tend to say it about any annual meeting of the EASD, but this time it is really special, just for one single reason. On Friday morning, the new version of EASD statement on how we should manage hyperglycemia in type 2 diabetes will be published, will be announced. And what we've seen in the draft version presented during the ADA scientific sessions in Orlando in June this year, this will be, from our point of view, like the countries like from Poland, this will be a radical change in the way we should look at people with type 2 diabetes and the way we should follow and intensify the treatment. So we all look forward to the presentations of the final version of this document, but it comes from the number of studies, cardiovascular outcome trials, which have been published since 2013. The major one was published, the first major one, which really was a game changer, was published in 2015, EMPARAG outcome study. But we have studies like that also presented during this meeting. We've just today had the Harmony study presented, and we will have more in the next 3 days. So these are from a clinical standpoint, and majority of EASD members and people coming here are just clinicians. It's about 50%. 30% are clinical researchers, and about 20% basic scientists. So from clinical point of view, this probably is the most important event we will have here, because it will have, I dare say that it will have global impact, not just on medical practice, therefore on patients' fate, but it should also have impact on policymakers, regulators, how diabetes care will be funded, how resources will be allocated. It's also critical for the industry, of course, because industry provides us with the tools we use to treat patients. We need constant service from the industry just to operate with these tools properly, and the research, the trials offers us the data. But we are eventually at the top of making the decisions more and more together with the patients. But I also say that medicine, diabetes care has become so complicated that basically very few patients are able to be independent in a way in collaboration with us. They have to trust us, and we have to make well-informed decisions. And these documents, prepared jointly by two main associations, I hope will be of great help, although, as I said, with its radical change of what we had before, it might be difficult to implement in many countries.
Do you think that finally the world is waking up to diabetes? By that I mean, I think the economic cost of diabetes is suddenly becoming all too apparent to governments around the world. And do you think that means that there's going to be a real impetus for change now?
Well, that's obvious for us. As you said, I'm a seasoned observer. I've been involved for over 2 decades, since middle of my studies, so it would be like almost 3 decades in diabetes care. And yes, that's obvious. It's a huge economical burden, social burden, not just individual one, not just the one suffered by a person with diabetes. The problem is that it's not the only healthcare-related burden put on governments. There are patients with cancers, there are patients with cardiovascular disease without diabetes. There are all sorts of other medical lobbies pushing on governments to spend money on their areas, not just on diabetes. We were actually pretty lousy in making governments fund diabetes care. Probably the best country where it was best achieved was like US. Switzerland, the ones who are the wealthiest ones. But at large, if you look globally, diabetes is maybe verbally put on the agenda, but if you look at healthcare budgets, it's not very high on the budgets anywhere. The problem with this is that it's a unique disease, which is well reflected in a change of terminology which is now happening. We try no longer to say patients with diabetes, we use the phrase people with diabetes or individual with diabetes, because this is the condition which once you have acquired it, you will live with it till the end of your life, and the life is getting longer and longer. So we have people living with diabetes 20, 30, 50 years, running their own life as normal as possible. So they work, they enjoy family life, they enjoy leisure time. It's not just that they have the disease and they are bedridden, homebound, and they can't do anything else. No, they look like you and me, and they just run their life as normally as they can. So if a government official look at an average person with diabetes, they say, it's nothing serious really. They just work, they have kids, they go for holidays, pay taxes, drive their cars, climb mountains. They don't need much help from our side. So it's not a spectacular disease in terms of visible suffering in majority of patients. Of course, if you develop complications, if you go blind, if you lose your limb, yes, that's traumatic. But fortunately, to the way how we treat diabetes, the number of patients suffering this deadly and extreme complications of diabetes is really coming down. I haven't seen a person who in Poland went blind with diabetes in the last decade. I've seen plenty of patients, of people with diabetes, who had visual impairment, but they don't go blind completely. So the government say, well, yeah, it's frequent. Yeah, you say it's serious, but it doesn't look that serious like cancer or car accidents or other traumas or myocardial infarction or stroke. So that's a difficult task. And I guess the world is still far from being woken up to the challenge.
But the point is, I think, that people are now realizing the impact that diabetes can have on their healthcare budgets. And I think that's the bit that's so alarming governments. I mean, we were just hearing in an interview earlier this day that in Kuwait, over 50% of their population now have diabetes.
Yeah,
I mean,
Saudi
that's
Arabia,
absolutely
Bahrain.
extraordinary.
If you go to India, it's close to 20%. Yeah, absolutely. India and Arab countries near the Gulf are the capital of diabetes world. Yes, but the government sees, they see the numbers and they say, oh, it's staggering. No, we can't cope with that. We won't fund new treatments, or we will limit the access to the treatments. We won't reimburse it because it will eat the whole budget of the whole country. And that's also the wrong attitude, because the number will grow anyway if nothing is being done. So it needs a courageous attitude from the government saying, okay, that's the amount of money we can allocate, and we will be proactive in fighting the diabetes epidemics. Very few governments have this approach. Also, there's another feature of diabetes. One is the numbers of the patients, which is also a drawback because no one really wants to face it. Those little visibility. Also, many people with diabetes do not say that they have diabetes, they hide it, so it also doesn't help to make the issue more public and the public make more aware. But another thing is that any investment, because that's what we like to call it, you don't, from the government point of view, you don't treat diabetes, you invest in diabetes care just to keep your population healthy and able to work for the next decades. But it is the decades. So you invest today as the Prime Minister, ruling party, or Minister of Health, and the income or the turnout from this investment will be in 10 years' time, where you will be long gone as a politician. Your opposition or successors in your own party will have fruit from your policy. So you really have to have a kind of a long-term perspective and a kind of a special political mind to understand that the policy you do as a politician is not just for today. It's with chronic diseases like diabetes, not the only condition, but the most prevalent like that, and the most debilitating, is you have to have this decade-long perspective. Very few politicians in democratic countries can do it. Kingdoms are better here.
And what's interesting is that actually the EASD is moving towards that prevention agenda. I mean, the Claude Bernard lecture this year was about prevention, and I think that that's where we're all going. Is that your feeling?
Well, the lecture presented by Professor Tłomi Lechta was the summary of his over 2 decades long research and studies, which, yes, they did change our approach to diabetes and pre-diabetes. They taught us a lot about prevention and how we should do it. The danger here is that the government sometimes say, okay, so we can't do much about people who already have diabetes, but let's concentrate on prevention. But it should be both. We should concentrate on prevention, we should concentrate on the treatment and the secondary prevention of complications. Prevention of diabetes is probably even harder challenge than treating the disease, because it's well beyond medical area. It's more about sociology, it's about culture, it's about kind of a social politics which can be run only from the highest level, with a well-designed cities, with a well-designed school curriculums, and so on and so on. We're not trained to do this as doctors. And this is not also what patients expect from us. This is something much greater than just the medicine. So I guess it's even the greater challenge, and it should start at the very beginning of our lives in kindergartens. This is where we should start prevent diabetes. So I would love to be a kindergarten teacher in my second life, in my other life, but in this life I'm pretty useless at it. So I'm not saying this prevention is not important, is vital, is crucial. But I also see the danger when the government say, oh yeah, let's jump in it, let's show that we can prevent that and that number of cases of diabetes. But we have patients now suffering and needing treatment now, just to keep them going, and not so they don't show their diabetes by having not a leg or cannot driving their car because they're so visually impaired.
Well, perhaps the EASD, one of its e-learning modules ought to be how to talk to policymakers about diabetes. I mean, that's a half in jest and half serious, because there's a really important thing to be done.
As a diabetes community, we've been doing it for years, not in the EASD, because we are now see the shift in the EASD activities, which is good, because diabetes has become a global issue at any level of our lives, from very personal to very general and at the high level of economics. But the organization which was really main task was dealing with policy regulators and all the advocacy work was IDF, International Diabetes Federation. Now we are somehow following their steps, but hopefully we will do together with IDF better, stronger, our voice will be heard. But it is a long journey, and I'm afraid majority of people who are here at the EASD annual meeting are, as I said, plain physicians as I am, because apart from all my international activities, I see patients every day. I run the hospital department. I'm on call. I have overnight duty. So I'm just a regular doctor, and most of the colleagues here are just like me. So I can talk to regulators. I also was the president of Diabetes Poland, Polish Professional Association. I did what I could, actually achieved very little, because the regulators didn't want to talk to us and want to listen, because they know they have no arguments and we have all the case and they have none. But yeah, sure, we should join, we should go outside of our scientific, let's say, ivory tower, and be more visible to the world that's outside and try to impact global politics. But it is a long run. But of course, if we do nothing, nothing will be done. So let's try. Yeah, absolutely.
So some very wise words from our wise man. And thank you, Leszek, very much indeed. And you can see that lecture, the Claude Bernard lecture that we were mentioning, on easd.org.